Well, hi, everyone. I'm Chad Cook. Welcome to another Shop Talk. We have Dr. Amy McDevitt with us today, and we're going to discuss her recent paper published in JMMT in 2022 titled Thoracic Spine Thrust Manipulation for Individuals with Cervicogenic Headache, a crossover randomized trial. Amy, great to have you on Shop Talk. Do you mind telling us a little bit about your background, your current role, and your research interests?
Sure, I'd be happy to. First of all, thanks for having me on this session. I'm excited to talk about some of the things that we figured out with this study. Essentially, I've been practicing about 22 years. The first 12 of that were all clinical, and then I started moving into the academic realm. It was really unplanned, but I kind of landed there, and Paul Mintkin was my mentor, and so ever since about 2013, I've been at the University of Colorado, Anschutz Medical Campus. I'm currently an associate professor there, originally teaching foundational courses, and now that Paul Mintkin has moved on to other opportunities, I'll be taking over the musculoskeletal track courses at the University of Colorado. Research interests, I've really always been interested in regional interdependence. So in the past, we've looked at a few studies that explored lateral inversion sprain, shoulder pain, and this particular study is about cervicogenic headache. I also like dabbling in educational research. So a lot of that is looking at clinical reasoning in physical therapist students. So that's another itch that I kind of love to scratch because I think it's just fascinating to learn how we learn and how our students learn. So that's kind of it in a nutshell.
Yeah, I saw a recent publication you had regarding education. And by the way, we're mutual admirers of Paul Mintkin. We think he's a good guy. We've been talking about having you on Shop Talk for some time, but you've been traveling all over the world. Can you give us a little summary of your experience? I think it was pretty amazing.
Sure. I was gone and now I'm back. This is really pre-COVID. My husband and myself, we decided to travel and take what's called like a family sabbatical. And we traveled for 8 months. We took our kids out of school. And so it was last January 5th, we left and we just got back to the United States about 2.5 weeks ago. So we traveled to South America. We did a language immersion in Central America and Costa Rica. We were in the Middle East for 5 weeks, which was fascinating. And actually, I think we had a call once, Chad, while I was gone. We had an 11-hour time change, but we made it. And then we spent the next couple of months in Europe and then in the UK. So really, it was an experience about people, culture, and it was fantastic. My kids are 13, and then I have twins who are 10. So they were really old enough to remember it, but young enough to appreciate the adventure. And now we're all back settling into our prior lives, which feel a lot more hectic than I remember, but we'll get there.
Well, that's going to be something they will talk about probably the rest of their life. And my understanding, your dog is in the car right now. So that
my dog is in the car. Yeah, we're trying to avoid any unnecessary interruptions during this broadcast.
I appreciate that. So let's talk about your study. And you were interested in looking at whether thoracic manipulation could reduce cervicogenic headache symptoms.
Mm-hmm.
And you opted to use a crossover trial, which I'll ask you about in a little bit.
Okay.
But why did you decide on thoracic manipulation for cervicogenic headache?
I think due to its proximity to the neck, the thoracic spine, as we know, can be a contributor to neck pain. We've also seen some contribution to shoulder pain. And a number of studies have already really explored this in detail. Further, I think when we're talking about cervicogenic headaches, we already know based on clinical practice guidelines that targeting the cervical spine, including the upper cervical segments, combined with exercise, so, strength-based endurance, really all are very optimistic interventions to treating this condition. But I think the team just wanted to know, in isolation, what's the power of just treating the thoracic spine? I think in some individuals, maybe they're more comfortable treating the thoracic spine because it carries less inherent risk. And maybe that goes for patients as well. But again, I don't love these studies where you just isolate one intervention and look at it. But in this particular instance, I think if we had combined thoracic manipulation with some of the other interventions that we already know are really favored, I don't know what we would have seen. So we wanted to just really take this down to a granular level and just look at thoracic manipulation in this particular case.
And you used a crossover design. Most people just use a this versus this. Do you mind describing to our listeners what a crossover design is and why you decided to use it?
Sure. And I'm gonna answer that question, but I'm gonna tell you something else first. And what I want to tell you is this little study was kind of like the little engine that could. So this study was designed by Paul Minkin, Paul Glynn, and Josh Cleland a number of years ago. And they put it together, I think back in 2009, applied for a grant, and they didn't get the grant. I revived this with Paul Minkin, and we applied for another university-wide grant, and we did not get the grant. Then third time's a charm, we got a grant through the American Academy of Orthopedic Manual Physical Therapists, but we still had to be really resourceful in how we did this because we just didn't have the resource to make this a large-scale study. So I found the crossover design intriguing, but it also really helped us in being able to calculate, kind of a smaller sample size, because in a randomized design, the participants serve as their own control. So we ended up with 48 participants, but 48 participants ended up receiving the treatment. It was just the timing that was different. So in a typical parallel design, you've got your control group and you have your experimental group. With the crossover design, you have the group that receives the intervention first, while the second group holds. And then this group number one, for example, is going to hold while the other group receives the treatment. So essentially, everyone is going to receive treatment. The timing is just a little bit different. The other caveat to this design is it's really meant for individuals who have some sort of chronic and stable condition. So you'll see this design in individuals with Parkinson's disease, with MS, so conditions that tend to kind of be a little bit stable. The nice thing about cervicogenic headache, unfortunate or fortunate, is that individuals tend to have these headaches for long periods of time. And in fact, our population at baseline, I think when we looked at baseline demographics, it was somewhere between 5 and 6 years was the average duration of symptoms for our participants. So that sounds chronic to me. And it ended up being the perfect scenario to at least try a crossover design.
By the way, thanks for adding that. I know that crossover is not appropriate for all conditions, like you mentioned, like acute low back pain. Crossover doesn't work because the order effect is so significant. First group it changes big time versus the second group. So I've neglected to ask you, what were your findings in the study? What did you find? Did thoracic manipulation help cervicogenic headache?
Yeah, to unpack that question is a little bit difficult, right? Because we're looking at certain limitations, like an overall small sample size compared to other large trials. The other thing I guess I would say is that we chose the wrong primary outcome measure. So again, before I answer your question, I'm going to say something to tell a little story. And the story is we wanted to look at a primary outcome measure that really appreciated headaches. And so we chose the headache disability inventory. Because of a lack of funding, we couldn't really pilot this study. We didn't have the resources to do a small pilot, which would have really informed us that the HDI was the wrong outcome measure. HDI retrospectively is really designed for individuals with migraine headaches. So some of the questions involve like your emotional state, your ability to concentrate, how your headaches have impacted your relationships and your quality of life. There were a few questions about pain and things that could kind of get at cervicogenic headache, but again, we chose the wrong tool. So thoracic manipulation and its impact on headache disability inventory, there was nothing to really talk about there. However, the secondary outcome measures that we chose were the Neck Disability Index, so the NDI, and the NPRS, so the Numeric Pain Rating Scale. And what we found when we looked at the group that had been holding versus the group that had an intervention is we did see some optimistic results. We saw statistical significance for both tools at that 4-week period. And then just to kind of back up a moment, our time points in this study were we did intervention for a period of 4 weeks. So That was the group 1, for example. If they randomized to treatment, then they got treated twice a week for up to 6 visits. And then we also grabbed outcome measures at 8 weeks and at 12. So again, I mean, we have to look at the results and interpret with caution, but overall, the results were optimistic that we did have some significance in our secondary outcomes. But I know you don't love p-values, Chad, so I didn't want to talk about the p-values specifically, but they did show, I don't know if you remember that from like 5 years ago at an AMT conference, you were totally bashing the p-values. So I want to tread lightly when we're talking about significant.
Well, I wouldn't take what I say too seriously, but first of all, thanks for reporting on the importance of an outcomes measure. And when it doesn't completely match up to what you're looking for, it can completely influence your study.
Yeah.
So yeah, I appreciate you saying that. To me, it's not, there are no excuses about mentioning that. That is that's actually very insightful for those that are designing a study in the future, I think.
Mhm.
So you teach at University of Colorado. You teach orthopedic students. I know you teach manual therapy, thoracic manipulation. Based on your experience with the study and your other experiences, would you teach thoracic manipulation to your students for cervicogenic headache?
Yeah, I mean, I think I would definitely share our findings, which again, I would say need to be interpreted with caution. But I think the caveat here is I would recommend it for individuals that have examination findings that support its use. So I think when we look at these studies, a lot of times if the approach is prescriptive, we're not appreciating what the examination findings were for these individuals because we can't, because that's not what we decided to do. But when we're treating clinically, it's pragmatic. And so we may have examination findings that support treating the thoracic spine in order to target individuals with neck pain or cervicogenic headache. I think further, if there's contraindications to cervical manipulation, which, cervical manipulation and mobilization are both supported in the clinical practice guidelines. But if there's a reason we can't do it, then I would say let's exercise our clinical reasoning and consider treating the thoracic spine. I actually had a patient in 2019. So this is really right around the time that the study was closing. And he had 2 subsequent fusions in his cervical spine, and he had cervicogenic headaches. And, it was like a kid in a candy store. I was like, I have an idea. So is that the norm? No, not necessarily, but he did really well. And it's anecdotal at best, but I did focus most of my manual interventions to the thoracic spine because that's what we were left with. And so I think there's a time and a place. I don't like saying that we should be prescriptive about certain things, but I think, again, if examination findings, are there to implement that intervention, then I would say absolutely.
In your study, you incorporated a couple of figures, and it was very clear from the figure to me that when the thoracic manipulation was the active intervention and the crossover, then that's where you saw significant differences in those individuals' reports of outcomes. Could you experience that as a researcher too, when you were actually performing the treatment and talking to the patients? Did you notice that difference?
It was interesting. So even though the primary outcome measure was a bust, I was really happy to see participants reporting an improvement. And remember, these are some individuals that had reported having headaches for 5 to 6 years. So even though the primary outcome didn't work out, I think the silver lining is, and as you can see from the figures, that the trend was really improvement in neck pain and general pain. We don't really know about cervicogenic headache symptoms based on the outcome measure that we used. Anecdotally, a lot of the participants did report that they had improvement. And I think to support that further is one of the outcome measures was the global rating of change. And so what we did notice is that the odds of reporting a clinically meaningful change on the global rating of change was present. So we did kind of reach that threshold of +4 after the participants had received the intervention. And so, I think that's a win. And something else that you and I had kind of talked about prior is that we're talking about close to 50 individuals that work on my campus that had been battling cervicogenic headaches for a long period of time. Many of them were still taking migraine medicines such as Imitrex, but really they met the criteria for cervicogenic headaches. So it makes me wonder, how good are we really in the medical community of really managing these headaches and identifying them? So I feel good about the results, having interacted with, almost all of these participants, because I was either the examining therapist or the treating. So yeah, that's kind of it in a nutshell, but I think the figures showed a trend towards improvement, which I think is good.
In my experience, it is a population where you can make life-changing differences in a patient. And I've had patients who will break down and cry in front of me because we were the first individual that is actually manipulated, and not thrust manipulation, but just changed their headache symptoms.
Right.
And so I think women's health, cervicogenic headache, you can make some big differences in that area.
I agree. And sometimes we had participants come in with a cervicogenic headache, and especially, with that type of musculoskeletal pain, they're very different if they're coming to see us for the intervention in the morning versus 4 o'clock in the afternoon. So there were times where we had individuals who had an active headache that reported improvement right after the thoracic package was delivered. And I think that's pretty powerful. And I think, we were really happy to help so many people, and actually also further to inform them about physical therapy and what it is that we actually do.
You mentioned thoracic package. Do you mind describing to the listeners I think you use more than one thoracic manipulation sequence, right?
Yeah, we did. And we used a treatment or an intervention package that's kind of been utilized multiple times in a number of studies. And so we decided to stick with that same package. So we did a seated CT junction manipulation. We did a seated mid-thoracic, so kind of anterior to posterior. And then we did a couple techniques in supine. So we did CT again in supine. We did kind of a mid-thoracic extension biased. And then we also did a prone extension bias technique. So we kind of did a number of these thoracic interventions to try to cover the whole thoracic region. And then each of the individuals followed that up with a thoracic mobility exercise, which is on the foam roller. I think we did 3 sets of 10 repetitions in 3 different areas of just thoracic mobility. And that was also part of what individuals that randomized into the experimental were doing concurrently with showing up for treatment.
Very nice. Yeah, there are some nice pictures. And what's really great, and I don't know if it was you all that did this or JMMT, Taylor and Francis, but the paper is open access. So for those who want to read it, you can read the full paper, and you can see actually nice pictures of the manipulation techniques.
And then I'll put a plug in. At the time, one of my students was or still is an artist. And so I asked her to do an interpretation, and she used watercolor. She used gouache specifically for those artsy people out there that also happen to be clinicians. And she did a really nice image. And so the editor at JMMT was like, we have to put this in color. And I thought that was lovely. So I'm putting a plug in for Mariah and her watercolor that we included in the manuscript.
That's interesting. I thought you got that from like Travell and Simmons book or something. That was really good.
Yeah, yeah.
So you all at University of Colorado, you've actually been really successful at recruiting in a number of studies and pretty high recruitment numbers. So what's your secret sauce in having success there? What are some tips you can give to those maybe in an academic setting that would also like to recruit?
Yeah, I think, the environment that you're in is everything. I think recruitment is hard, just point blank. It's challenging, but I think we're really fortunate because we have over 19,000 people on our campus. So we have 3 hospitals. We have a children's hospital, a VA, and then a large, it's between 600 and 800 bed hospital. And then we have multiple educational programs. So to be able to recruit from that pool, I think is really helpful. We also have on our campus, the department that kind of oversees all of the research on the campus sends out a listserv once a month with all of the active studies that are looking to recruit. So they make it really, they make it really helpful for people that are trying to do research, whether it's large scale or small scale, to get in touch with potential participants. But then if you don't have that, I really leaned on some of our student researchers who, volunteer to help with various studies. They really served as the liaison between myself and other students on campus. I leaned on my physician colleagues and then my clinical colleagues. So I also practice at a sports medicine clinic that's affiliated with our hospital system. So they let me kind of advertise in that area too. Recruitment is hard. I mean, I feel lucky that we have the resources that we have, but time is precious, and people are used to putting up with a lot, meaning they might have a headache for 5 years, but they may not feel like they really have the time or the bandwidth to exercise self-care. So I think that's one of the barriers, but I would say you have to exercise every potential venue you have to spread the word about what you're doing and why you're doing it.
You are so right. Recruitment is so difficult. And this is why I am rarely criticize studies, is because it's so difficult to recruit and to do research, and good on you for doing that. Amy, if you had and I always ask this question, it's a little corny, but if you had a 1-minute elevator talk and you had a whole elevator full of OMTs at AOMPT, and they said, oh, we've never heard of your study, what would be your one-minute elevator talk about your research study?
Okay. Well, my first reaction to that question was, if you had a whole elevator full of OMPTs, they're not going to let anybody talk because we're always talking. But if you were to be quiet and let me talk for 1 minute, I guess I would say, we did this clinical research study on looking at thoracic manipulation because our research aim or question was really about the power of regional interdependence. We looked at individuals that had cervicogenic headache, and we found optimistic outcomes that help individuals with neck pain and neck disability. And so it's something, and this is our, our typical kind of blanket statement in the conclusion section. Further research is needed. But if we don't start by piloting these smaller scale studies to see what's happening, then we don't have the ability to really come up with broader and bigger and more important research questions. So in a nutshell, that's our little study.
Well, that's a good elevator talk. So Amy, you're on Twitter or any other social media platforms where people can follow you or connect with you?
I'm on Instagram, I'm on Twitter and Facebook, and I think that's about all I can handle at this point in my life.
Yeah, that's a lot. And PubMed as well, right?
And
they can follow your work on PubMed.
Sure.
Any last comments for the listeners? What you got brewing? Anything new?
Well, first of all, I'd be remiss if I didn't put a plug in for Cardin Rehab. Cardin Rehab supports small scale grants for clinician researchers, and that's through the American Academy of Orthopedic Manual Physical Therapists. So this is the third time that MARDIG has given my team a grant, and some of these even smaller scale grants are enough to just fuel the research question and get it going. And so I think it's really important. And then my co-authors, I don't know if we mentioned who they all were, but the co-authors are Paul Glynn, Paul Minkin, Josh Cleland, Dan Roan, and then we had 2 students at the time, Rebecca Altick and Drew Courtney. Our students are workhorses. And so another plug, if you're doing clinical research, is students are hungry to learn, whether it's paid or unpaid, and they're an incredible and valuable resource in getting work done. So I'd like to put a plug in for them. What we have brewing, I'm trying to finish a PhD, so I'm trying not to pick up too much more work unless you're asking. So that is exploring anterior shoulder pain. So I'm wrapping up a few projects there. And then I'm also working with a really exciting group out of Creighton University to really talk as much as we can about clinical reasoning and what are the best ways that we can really integrate learning sciences into DPT curricula to really optimize what we're teaching and make sure that we're all accountable for really making the experience the best that we can for our students. So those are some other things that I'm currently working on.
Well, thank you so much for acknowledging all those folks and Cardin and everything. Research takes a team. So,
Yeah.
and which is one of the reasons why I hope your positive mojo continues forward with our grant that we wrote with Brian O'Howler. And so hoping for success with that. You still found time to work with us on that. So I appreciate it.
Yeah, I'm excited, and I'm crossing fingers and toes that that one comes through, because I think that's a really important topic.
So Amy, thank you so much for sharing your work on Shop Talk, and we hope to speak soon again. Thank you so much.
Thank you.